The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Now, before we get started, I'll introduce our speaker. Dr. Edward Quadros serves as a research professor in the Department of Medicine at SUNY Downstate Medical Center. Research in his laboratory is focused on fetal and neonatal brain development and the role of folate and B12 in this process. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. For today's webinar is partially funded by Local 25 of the Teamsters in Boston, Massachusetts. So, Dr. Quadros, I want to start out by just introducing you and ask you to tell us a little bit about your research on cerebral folate antibodies.
Good afternoon, everybody. This is Dr. Quadros at SUNY Downstate. The story of folate receptor autoantibodies started in around year 2000 when we were looking at causes of pregnancy-related complications, including neural tube defects. It is at that juncture that we identified autoantibodies to the folate receptor in women who had a baby with a neural tube defect pregnancy. This indicated to us that there was a problem with transport of maternal folate to the fetus, and these antibodies were causing it. Subsequently, we looked at a rare condition known as cerebral folate deficiency syndrome. This syndrome presents as neurodevelopmental disorder with overlapping symptoms similar to that seen in autism spectrum disorders. One characteristic of this syndrome is that they have low folate in the CSF, thus providing evidence that folate transport to the brain is affected. It turned out that these kids all turned out to have folate receptor autoantibodies. And we have subsequently shown that these antibodies can do two things. One is block folate transport, and two, cause localized inflammation. Both of these can contribute ultimately to a defect in transport, and in the case of cerebral folate deficiency and autism spectrum disorders, basically folate transport to the brain, or in the fetus, it is maternal folate transport to the fetus. Having said that, we have now, in recent years, identified these folate receptor autoantibodies in a majority of children with autism spectrum disorder. Over 60 to 70% of these children are positive for these antibodies. And incidentally, when treated with high-dose folinic acid, significant improvements are seen in core presentations of autism. So this is, for the first time, a marker and a treatment to which these kids respond to has been provided. And we are very excited about this whole thing in terms of going forward with clinical trials, and we are looking forward to that.
Okay, well, thanks so much for that overview on the research that you're doing. I think the first questions that we have, it looks like most of them are pertaining to exactly what drove you to get interested in the possibility of treating this. So what created that question for you? And then also, how did you meet other colleagues who are interested in this research?
Well, this laboratory for a number of years has been looking at B12 and folate metabolism. And one of the issues that we had tackled early on was to look at a rat model of folate deficiency. And clearly, there is a connection of folate deficiency going back to almost 5-6 decades, that folate deficiency during pregnancy causes pregnancy-related complications. So when we looked at the rat model of folate deficiency, what we noticed was that they would have difficulty in getting pregnant, as well as develop fetal abnormalities. Subsequently, we asked the question, if we injected these rats with an antibody to the folate receptor, would we see a pathologic condition similar to basically dietary folate deficiency? And it turned out that rats injected with the folate receptor antibody developed fetal abnormalities, especially in the development of the neural tube. So providing a clear link between the presence of the antibodies and the pathological effects in the developing fetus. We subsequently looked at women with the neural tube defect pregnancy primarily because for a number of years we have known that women who take large amounts of folic acid reduce the risk of having a child with neural tube defect. However, these women were not folate deficient. They did not have any of the metabolic markers such as elevated homocysteine during pregnancy, yet they had a high risk of developing a child with a neural tube defect. So we asked the question, could there be an autoantibody mediated effect in these women? And lo and behold, our first study indicated that 70% of these women who had a history of a neural tube defect pregnancy were positive for the antibody. And so that's what started the whole process moving along. Then came along the cerebral folate deficiency syndrome, whereby they had already looked for all kinds of genetic abnormalities to explain the neurodevelopmental disorder in these children and couldn't find an answer. Now, one observation that Dr. Raymaker, who was practicing in Europe, made was that all of these kids had low CSF folate, but he did not have an explanation for this, yet he started treating his patients with high-dose folinic acid, and they were showing dramatic improvement. So when he found out about our work on the folate receptor autoantibodies, he contacted us. And when we analyzed his patient population, we found that over 80% of his kids were positive for this folate receptor autoantibody. So that started the ball rolling, connecting neurodevelopmental disorders with this autoimmune disorder contributing to cerebral folate deficiency. It's the next stage that we finally looked at the autism spectrum disorders, and again we found the same observation there, that over 70% of these kids have the autoantibody, and they responded reasonably well to high-dose folinic acid treatment.
Okay, so the next question that comes out of that is, so how are you testing for folate deficiency? Exactly what is the test and what does it measure?
So the ideal test for cerebral folate deficiency is doing a spinal tap and getting CSF samples for folate analysis. This is not an easy task. It's not something that many parents will consent to. However, measuring folate receptor autoantibody can be done very simply in the laboratory, drawing a small amount of venous blood. So the presence of folate receptor antibodies is a strong indication that there is a problem with folate transport to the brain. So it provides a test to easily identify this autoimmune disorder, and if it is there, then clearly these kids need to be treated with folinic acid. Now, the reason why they're being treated with folinic acid is folinic acid, which is a reduced form of metabolically active form of folate, can be transported via a different pathway, a different mechanism to the brain, even in the presence of the folate receptor autoantibodies. And this is why that form of folate is the preferred choice.
Okay. So talking about the preferred choice, so that form of folate, how do people obtain that? Is it available over the counter or is it strictly prescription?
Now, folinic acid at the doses that we prescribed, which is very high dose, 1 to 2 milligrams of kilogram of body weight, typically not to exceed 50 milligrams in a day. This is what the clinicians have been using. Will have to be obtained by prescription. However, there may be smaller doses, such as 5 to 10 milligrams, that may be available online or through pharmacies without a prescription.
So what is the medication you're talking about? I believe it's leucovorin is the prescription.
So, folinic acid that is available is calcium leucovorin. It's a calcium salt of folinic acid, and it is in a racemic form. That is, means there is a half of it is active, half of it is inactive. Now, some physicians have been prescribing methylfolate. Methylfolate is also a physiologic form, but it has to be further converted via a vitamin B12 dependent pathway to the reduced forms of folate, but it can be used in the place of folinic acid if it can be obtained readily over the counter.
What is leucovorin typically used for? What's its...
Typically, leucovorin has been in medical use for the past 5 decades. It is used as a form of folate to basically counteract the effects of chemotherapy in cancer. It is a form of folate that can rescue from the toxic effects of the chemotherapeutic drugs, such as methotrexate or 5-fluorouracil, which are anti-cancer drugs because they block folate pathways. Leucovorin is not a cancer drug or an anti-cancer drug. It's basically a vitamin, but it rescues from the chemotherapeutic toxic effects of the drugs. So it's widely used in cancer chemotherapy to rescue a patient from the toxic effects. In this case, it's being used as a vitamin, as a nutrient to provide adequate flow of folate to the brain.
Okay, so this person is asking about a phenotype. He's saying, what is the phenotype for autistic patients with folate antibodies?
Well, I'm not aware of any specific phenotype. We know that the whole autism spectrum disorder, over 70% of these kids are positive. That means there's a clinical phenotype, basically fits into the whole spectrum disorder. There is no specific genetic phenotype that has been identified or a clinical phenotype that is closely associated with only the folate receptor antibodies. A lot of neurodevelopmental disorders, including Rett syndrome, cerebral folate deficiency syndrome, and autism spectrum disorders, all are a developmental phenotype for the folate receptor autoimmune disorder.
Okay, so this person's asking about connections to other genetic markers. Specifically, they're asking about the MTFHR and or the MAR. They're asking if there have been any research studies or connections with those different issues.
Now, looking back at the literature, you will notice there is an association described between MTHFR polymorphism and requirement for additional folate. So MTHFR polymorphism basically prevents methylfolate being formed. So providing a larger amount of folate basically pushes the reaction and provides adequate folate for subsequent pathways that utilize folate. It is not a major issue in the case of autism spectrum disorders because these kids, when they are positive for the antibody, they are treated with a fairly large dose of folinic acid or methylfolate. So any effect that is due to polymorphism is automatically eliminated and adequate folate is provided.
Okay. So if a child reacts negatively to the 5-MTHFR form of folate, is that indicative of what does that mean in terms of their antibodies, or can we make any judgment from that?
Now, if a patient is given folinic acid, the MTHFR polymorphism does not play a major role because folinic acid can incorporate directly into single carbon exchange reactions and DNA and RNA synthesis before it reaches the methylfolate trap pathway. Now, so giving methylfolate, there is a certain disadvantage in the sense that you have to make sure that the B12 status of the patient is normal or adequate, because that methylfolate then has to be converted back to further reduced forms of folate, such as tetrahydrofolate, via a B12 dependent reaction. So when giving methylfolate, you have to make sure that the B12 status of the patient is normal.
Okay. So this is kind of jumping to a totally different part of development, but they're asking about pregnancy. So prenatally, are there considerations that a parent should be taking? So a woman who is pregnant, in terms of folinic acid, I know there's a lot of discussion about this and back and forth. So how does this relate to the work that you've done?
Now, prenatal folic acid is now pretty much prescribed in all countries, but this prescription is typically done within, in the first trimester of pregnancy. The consensus in the folate field is that women should be folate replete before and throughout the pregnancy. Now, we have published data on folate receptor autoimmune disorder contributing to subfertility, difficulty in getting pregnant, and miscarriage, and so forth. So again, there is an association with folate deficiency and pregnancy-related complication. So the clear message from here is that a woman, before she gets pregnant, she should be replete of folate. In fact, looking at parents of autistic kids who are also positive for the folate receptor antibody, I think for the outcome to be normal, in situations like this, both parents should be on folate and should be in a normal, totally folate replete status before conceiving, and of course the woman throughout the pregnancy.
Okay, so here's a question completely unrelated to that, but they're asking about animal milks. So asking about provoking agents that is related to anti-folate receptor antibodies. So has there been research or a connection between consumption of milk and this issue?
Okay, I'm glad you asked this question because there is a lot of misconception out there about the use of different animal milk that may be more suitable for autistic kids. Now, back in 2004, when we first time identified cerebral folate deficiency syndrome, we made a connection between milk intake and the increase in the titer of the antibody. In fact, we took a group of these kids and put them on a milk-free diet, and their antibody titer decreased. We've also done studies to show that milk, from many animal sources that we've tested, has a high amount of folate receptor alpha. This can act as a trigger to boost the antibody titer in people consuming milk. So in fact, for autistic kids and CFD patients, being on a milk-free diet is very helpful because it reduces the antibody titer. Now, there has been some discussion about camel milk, that it may be more appropriate and autistic kids may tolerate it. In fact, the camel milk also contains folate receptor alpha, and in fact, it is as antigenic as bovine milk in terms of reacting with the antibody that these kids produce to the folate receptor alpha. So my recommendation is that if a child is positive for the folate receptor antibody, the child should be taken off any animal's milk.
Okay. The next question is about commercial lab testing. So this person's going to know about commercial labs where folate antibodies can be done and how a doctor would order those. And are they worldwide? Are they in specific regions? What do we know about that?
Okay. The test that we were doing at SUNY Downstate Medical Center is now performed by a private laboratory known as Iliad Neurosciences. They are located here in Pennsylvania, and they will provide both the blocking and the binding antibody test to patients requesting them. They should go to their physician and request the test through them, and the physician will then draw the sample and send it to the laboratory for testing.
So they need to work with a physician specifically, though. They would have to educate their physician about the testing and then obtain the.
My recommendation is that they work through their physician and not just randomly send samples to the testing laboratory, but work closely with the physician, get the test, and then get appropriate consultation for the folinic acid treatment.
Okay. Relating back to the milk question, this person's asking about colostrum. How does that relate to that same issue about consumption of animal milk?
Colostrum is basically milk, and it also contains the folate receptor alpha. That protein is just as immunogenic in regular milk, so it doesn't matter which source of animal milk you get. Especially bovine and camel milk antigen is highly reactive against the autoantibody. Goat milk is slightly less reactive, but the whole question here is, so you give a child the milk and the child's antibody titer goes up. What this is telling us from a scientific point of view is that there is a problem with the gut in this child, either due to inflammation or there is some kind of a chronic event occurring there, whereby the immune system, the gut immune system, is recognizing the antigen in the milk. So in these cases, I think they should work very closely with their physician to make sure that the gut inflammation issue is taken care of before the child consumes milk. One of the recommendations that I have made and other physicians have made is that in a newborn, try to put them on mother's milk for as long as one can, because the longer you delay introducing the offspring to milk from other animal sources, the better the chance of developing an immune reaction to these foreign antigens.
So what you're saying is mother's milk, even though technically it is animal milk.
Yeah, but it is antigen that is naturally present in the mother and the offspring, and the baby is less likely to react immunologically to it.
Yeah. So it is different than when you're introducing animal milk. And there have been a lot of questions here about different forms of animal milk and kefir, but I think that the takeaway here is that any animal milk that's not mother's milk is...
Yeah, in fact, milk in any form is bad for those who have the autoimmune disorder.
Okay. Or at least it will trigger some sort of reaction typically.
Yes.
Right. Okay. So I'm getting a lot of questions about age of initiating this treatment. So is there a particular age where the benefit is higher? So for example, if they start treating with folinic acid at a younger age, is that going to have a longer or a better outcome? Or is there no age at which it's too late to start? What has been observed there?
Okay, and in any event where the brain is involved, the earlier you detect, the earlier you diagnose, and the earlier you treat, the better the outcome. So that applies to cerebral folate deficiency syndrome as well as autism. Early diagnosis is critical, and once the diagnosis is made early, introducing early treatment is absolutely important, and I think it will result in a better outcome. In the case of CFD, Dr. Raymakers in Belgium has in fact shown that when a child is diagnosed before the age of 2.5, 3, you can basically prevent a lot of the neurologic developments if the child is rigorously treated with folinic acid. As the child gets older, it becomes to reverse many of these neurologic developmental disabilities. So the take-home lesson from here is that try to get a diagnosis early on and treat the child early.
The other question, though, is have you seen benefit in introducing treatment even when somebody is older? So say you have a 14-year-old or a 25-year-old, would there still be benefit to it?
Yes, in fact, the first double-blind clinical trial that was published last year by Dr. Fry and myself used kids in the range of 5.5 or 6 to 12.5. So they were older kids. And here, these kids, they were in the spectrum, and the most improvement we saw was in language, social interaction, communication, attention, and so forth. So yes, there is a benefit even in older kids to treating with high-dose folinic acid. And the response to treatment was best in those who had the folate receptor autoantibody.
Okay. Can you talk a little bit about that testing, about the difference between the two, the binding and the blocking, and how that test is interpreted?
Yes, so there are two types of antibodies that are identified. One is called blocking antibody. What the blocking antibody does is it binds to the antigen, which in this case is the folate receptor alpha, and in doing so, it blocks folate binding to the antigen. That means it binds to the active site, and then it prevents blocking of folate, and as a result, folate transport is affected. The binding antibody, on the other hand, recognizes an epitope that is distant from the active site, that is the folate binding site. So it binds to an antigenic epitope far away from there, and folate can still bind. But what happens when an antibody binds to an antigen is there's an immune reaction, there's inflammation. End result of that is the folate receptor alpha is destroyed, again affecting folate transport. So both blocking and binding type antibodies are pathologic because they both affect folate transport, but by slightly different mechanisms.
Okay. So I'm getting a lot of questions about high-dose folinic acid in terms of safety. So if this is detected, is this a lifelong ongoing therapy that people would engage in? And are there safety concerns about long-term use?
Now, folic acid at the doses that is used is fairly high dose. However, the advantage of this is it's been widely used for a number of years in cancer patients, even at high doses. There's a very nice, clear safety profile for this vitamin. The one other advantage is that it's a B vitamin, it's a water-soluble vitamin. Typically, when you give a large dose of this folinic acid to a patient, within 24 to 48 hours, most of the excess is cleared, tissue uptake takes place, so there's a large component of this is excreted. Now, talking to physicians who've been treating patients with high-dose folinic acid, I'm made aware of the fact that these children may have to be on this treatment pretty much for life, perhaps not at the high dose, perhaps at a maintenance dose, but there have been instances where they have withdrawn the treatment and the child has reverted back. So based on that, I would say, yes, they may have to be on long-term treatment, maybe for life, but perhaps at a maintenance dose, not necessarily at the high dose that was initially prescribed.
And at that maintenance dose, there would be fewer risks?
There are known risks of taking large amounts of water-soluble vitamins such as folinic acid. Now, if you look at the literature, there are some very few studies that talk about the increased risk for cancer because folinic acid, after all, is the basic component that stimulates cell replication and DNA synthesis. So the presumption here is that if you constantly take high doses of this vitamin, which is directly involved in DNA synthesis, that you may trigger a benign cancer into developing into a malignant cancer. Now, the chances of that benign cancer becoming malignant are probably remote, but however, there is a chance that a small malignant growth may be stimulated to grow faster. There is no strong evidence, but there is some literature out there indicating this. However, in the case of autism and developmental disorders, you have to weigh the risk benefits here. And clearly, treatment with folinic acid, if it is helping these kids, and early treatment is reversing the neurologic development, I think the risk of cancer consideration is very low.
Okay. The question is about testing and retesting. So this person's saying they tested their child at a pretty young age and they found blocking antibodies. They're wondering, they've been using leucovorin for several years, and they're wondering if they would anticipate a change in the antibodies over that time or if they stay consistent.
Now, the testing of antibodies should be done once in a while, even when the child is on treatment, just to monitor the progress of the autoimmune disorder. It is clear that the antibody titer can vary with dietary milk intake or other dietary milk containing product intake, or basically the disorder itself becoming more severe or less severe. Like any other autoimmune disorder, the antibody titer varies. And testing it maybe occasionally gives the physician an idea about the autoimmune disorder status in the patient and maybe help him to prescribe a higher dose or maybe other medications to basically counteract the effect of the antibodies.
Okay. The next question is about dosage. So you've talked a little bit about this already. You talked about it's related to weight. So could you review that figure and talk a little bit about how dosage is assessed and adjusted, and then related to how they react to it or respond?
Sure. Dosage from anywhere from 1 to 2 milligrams per kilogram of body weight, not to exceed 50 milligrams into 2 divided dose of 25 milligrams each, has been advocated. However, ideally, most physicians may start at a dose of 1 milligram per kilogram body weight and see how the patient reacts. Occasionally, a patient does not react too well. There are some issues, sometimes an increase in certain clinical presentation. And if the physician feels that the patient is reacting adversely to the 1 milligram or 2 milligram dose, they typically reduce the dose as low as 0.5 milligram per kilogram body weight. So it's a matter of the best judgment on the part of the physician what the child can tolerate in terms of daily dose. Now you have to realize that this administration is oral, that only a fraction of what is administered is actually absorbed, because there's a limit to how much can be absorbed by the gut. So even though the dose is given at 1 or 2 milligrams per kilogram body weight, only a small fraction of that is actually absorbed and goes to circulation and distributes to the tissues.
This is asking about awareness. So are most pediatricians aware of these issues? How can they educate their doctors about it? Are there studies they can print? Is there information from the lab that they could share?
From my own interactions with some parents and physicians specializing in autism treatment, my impression is that most pediatricians, general family doctors, are not aware of this, and in fact are reluctant to treat patients, even autistic patients, with folinic acid. So educating physicians and the general public, I think, is an important aspect of basically spreading the word. And in addition to that, I think one thing we should emphasize is early detection is a key to basically reversing, improving the outcome. So again, recently there have been 2 publications that talked about measuring cortical hypertrophy in infants as young as 6 months of age. What they found out was that there was no treatment aspect to this. They found out that when baby is born to mothers who already had an autistic child, who have a higher risk of having a second autistic child, monitored at 6 months, 1 year, and 2 years, if they found that cortical hypertrophy and increase in brain mass, there is a high chance, almost 96 to 100% chance, that the child would be autistic. Now, this is an important finding in terms of early diagnosis, and I wonder what would happen if you notice this as early as 6 months to 1 year and introduce a treatment like folinic acid. Would you totally reverse the outcome? This is a question, of course, has to be answered with clinical trials, and I'm looking forward to maybe somebody initiating such trials.
Okay. So in terms of reception in the research community and in the medical community, I think you're saying we're just getting started, that more trials are needed, and that a lot of physicians are still in the learning phase.
I agree with you totally there. Clearly, more clinical trials are needed. Funding has been difficult, and so there are constant need to, basically gather enough funds to start these clinical trials. Here at SUNY Downstate, we are trying to initiate a clinical trial, in fact, 2 clinical trials. One is treating autistic kids from a younger age onwards, and the second one is actually identifying parents who already have autistic child and treating them before the woman gets pregnant and seeing what the outcome is. These are very interesting ideas, but they have to be then tested with properly designed clinical trials. Of course, a lot of money is needed for such trials, and we are struggling to raise money for these things.
All right. In the discussion of dosage, you talked a bit about, I think you said the maximum dosage is it 50 milligrams a day? I think that's what you said. So
yeah.
Regardless of, how big the individual has grown, so say they've been taking it for 5 years during, from age 6 to 12, that dosage would never exceed that threshold?
The dosage should not exceed, we have not tested a dose exceeding 2 milligrams per kilogram. And no matter what the weight of the child or the young adult is, should not exceed 50 milligrams in a day.
So that's consistent, even if they get up to 150 pounds, we'd still.
It doesn't matter, no, because that's more than adequate to transport enough folate. Just giving a lot more dosage doesn't mean that it's all going to get absorbed. In fact, a lot of it will be excreted out.
Yeah. But the body naturally excretes it rather than having.
That's right. Yeah.
Okay. All right. So the next question, this person's asking about the difference between just a blood draw and a spinal tap. So you talked a bit about that. So they want to know, is it significant? I mean, I would assume it's much more accurate to do the spinal puncture, but maybe you can talk a little bit about the difference and the reliability of those two methods.
Yeah, the spinal tap is a complex, risky procedure where a trained neurologist has to do it. It involves hospitalization, and it's an invasive procedure, whereas a blood draw from a vein is a very simple procedure, and I think it can be readily done. So the question is, do you really absolutely need a spinal tap? My answer is no, considering the risk, and most parents will not agree to it. So unless a spinal tap is needed, not just for measuring folate status, but maybe diagnosing other issues, then yes, the neurologist may recommend that they still go through a spinal tap. But in terms of detecting cerebral folate deficiency syndrome and the folate receptor autoimmune disorder, at this stage of the game, I don't think we need spinal tap. A simple blood test should do it. In fact, one of the things we have noticed is that in patients who have the folate receptor antibody don't have low folate in the serum. In fact, they may have slightly elevated folate because it's not going to the brain and other tissues. So the antibody presence is a good indicator of folate transport to the brain.
Okay, so what could a parent or a clinician say to a neurologist who says that blood testing is not reliable and that only a spinal tap is worth doing?
Well, if, this depends on a specific situation where the neurologist makes a decision not simply to measure folate status in the CSF, but for other reasons. And I think we should leave it to the judgment of the neurologist and the parents.
Got it. Okay. So totally switching gears here. This person is asking about measuring response to treatment. So in your studies that you've done, what instruments did you use to measure improvement? So was it a battery of behavioral tests, or what were were you measuring, or was it strictly blood work? What were the different methodologies used?
Okay, this is a question really that should go to a behavioral psychologist and a autism specialist physician. However, what I can tell you is that what we have seen the most response to is in language, communication, social interaction, attention, and basically general well-being. So the improvement in language has been very significant in these older kids that we have tested. And the work that Dr. Raymakers has done with the younger kids has seen remarkable improvement in basically many of the neurologic presentations, such as the repetitive movements of the limbs, gaze, and so forth, which are more serious indication of neurologic involvement. And you see improvements even in these deficits in younger kids. But as far as autism spectrum disorders is concerned, since most of the study was done in older kids, like 5.5 years and onwards, the major improvement has been in social interaction, language skills, and so forth.
Okay, this is a clinician asking. He wants to know, you had mentioned that testing should be recurring, that it should happen over time, just to check on status. How frequently might they do that?
Okay, if an autistic kid is tested initially at the first time, and the test comes out negative or low titer, I think after 3 to 4 weeks, the test should be repeated, because the antibody titer can significantly vary. Like most autoimmune disorders, the circulating antibody pool changes over time. So antibodies are produced, they disappear, then they come back again. And this is typical of most autoimmune disorders. Similarly, in this case also, the titer can vary. So if the initial test comes out negative and the physician is suspecting folate receptor autoimmune disorder, I would say the test should be repeated again 3 to 4 weeks later. Couple of repeat and still comes out negative, then you can most likely rule out folate receptor autoimmune disorder.
Okay. This person has an interesting question. They're asking about correlation to how affected an individual is between binding and blocking. So if a person has just binding or just blocking or a combination of the two, is there any kind of correlation between symptoms and how their testing is interpreted?
As I indicated at the beginning of this discussion, both binding and blocking antibodies are pathologic. The blocking antibody was found primarily in CFD, of cerebral folate deficiency syndrome. In autism, we find both binding and blocking antibodies. The difference between the cerebral folate deficiency syndrome and autism spectrum disorder is the CFD patients seem to have much higher titers of these antibodies, whereas autistic kids seem to have, majority of them, a lower titer. Yet, I must emphasize that titer at any level is pathologic. The titer varies from time to time, and depending on other immune stimulation, as well as antigen intake in the form of milk. But when a test is sent out to a laboratory, the test comes out negative, then clearly the patient is negative for the antibody. You repeat the test again, 3 to 4 weeks later, it still comes out negative. Most likely the patient doesn't have the autoimmune disorder. However, if the test comes out positive, no matter how low the titer is, the patient has the autoimmune disorder. The titer most likely will fluctuate from time to time, so it's best to repeat it after a few weeks to make sure that the titer is still low, or has it gone up.
And you're saying after a few weeks, so for an ongoing maintenance, if you're prescribing leucovorin over time, a physician might want to test every year, or would you suggest every 6 months? What would be a interval date?
I mean, again, it'll depend on the response to treatment and maintenance doses given. And if the physician feels that if he's repeated the antibody a year later, the titer is about the same or gone down, he may not have to repeat it every year unless there is a medical reason to do it, like the condition will worsen or so forth. But other than that, I would say that repeating the test a couple of times during the course of treatment and then deciding that, yes, the patient does have the autoimmune disorder and we will have this person on folinic acid throughout, maybe at a low maintenance dose. This is a decision that the physician will have to take.
Okay. This person's asking about once they're on leucovorin, if they're on the therapeutic dose, will that impact how their testing comes out? So would it affect what the testing says? So if they're on their maintenance dose.
Okay, this is an important question, and we have tried to address this because a patient who is on high dose fulinic acid has taken the fulinic acid the day before and comes for a blood draw next day and for the test. This is not recommended. Because of the high circulating folate status, that can interfere in the assay and give you a false positive blocking assay. So my recommendation is that the patient be taken off fulinic acid at least for 3 to 4 days prior to testing.
To get an accurate assessment.
Yes.
Okay. So you talked a bit about research funding and the ongoing need. In terms of the existing research that's out there, do you have it on your website, or is there a common website where people might go where they could find most of the studies that have been done on this?
I mean, most of the studies done by my group, Dr. Fry's group, Dr. Raymaker's group, is all available on PubMed because a lot of the work is published in peer-reviewed journals, so it's available there. I don't know of specific websites that caters to the general population.
So the best thing they could do is just do some searching on PubMed to find
or even Google search.
Right. They'll come up on Google. PubMed's generally a subscription service for at least for some of us. So. Yep.
A lot of the work that has been published appears on Google also. Google is an excellent media to basically search for pretty much anything.
Okay, great. So parents and clinicians who are listening can go and search for them and probably find quite a bit of information.
Yes.
Okay, so another question that came up is about the difference between fulinic acid and methylfolate. So does the form matter? What are I know that you've talked about this a little bit, but these questions keep coming back up.
Yes, as I indicated in my early discussion that methylfolate can be substituted for fulinic acid, but they have to make sure that the B12 status of the patient is adequate because that methylfolate has to be then converted into tetrahydrofolate and fulinic acid subsequently for metabolic use. So if the patient is B12 deficient, the methylfolate gets trapped. So the patient becomes folate deficient. So you don't want that to happen. So if methylfolate is given, my late recommendation is that the patient also be given small doses in microgram doses of B12 to make sure that the patient is not B12 deficient.
Okay, here's a question about other issues that could provoke the antibodies. We talked about milk. So what are some other immunological problems that you think could trigger this? I mean, would there be infections? Could it be related to sort of the PANS and PANDAS issues where people have strep vulnerabilities? Have there been any other hypotheses about triggers?
No. The folate receptor alpha, to which the autoimmune disorder is attributed to, is a membrane, peripheral membrane, a lipid or GPI anchor-linked protein. These proteins typically are highly antigenic. There are other instances of disorders where GPI-linked proteins become antigenic and become autoimmune in response. And folate receptor happens to belong to that class of proteins. So in this instance, yes, it is highly antigenic, but then the question may be, why doesn't everybody become develop antibodies? It's like any other autoimmune disorder. Some people are more susceptible to this autoimmune disorder, others are not. Now, one thing I can tell you is that parents who are positive for these antibodies do not, at least as far as we know at this stage of the game, do not have any neurologic involvement and so forth. So the antibodies, if they develop in adults, they may not be pathologic to the brain. It is the fetal brain and the infant brain that are highly susceptible to this folate deficiency, and also whether it is if it's mediated by the autoimmune disorder. So it becomes very important to diagnose, identify, and treat basically the fetal stage as well as the early infancy in terms of a positive outcome.
Okay, great. So we've got just a couple more questions. One question a parent had was about sleep. We've talked a bit about other manifestations, but has there been any kind of link between this problem and sleep disturbance?
Now, whatever little I know about sleep and autism, it's a very complex issue, and I think many factors are in play when it comes to sleep apnea or inability to sleep, whether it is autistic children or even normal people. So I don't think I would want to comment any further on this.
Okay, that's completely fine. This person is asking about binding versus blocking. If your doctor wants to test only one or the other, would it be beneficial? Would there be a reason why you would just test one or the other, or would you typically recommend testing everything?
My recommendation is to test for both, because the blocking antibody measures antibody. It doesn't matter whether it's an IgG or IgM. It measures all types of antibodies because it's a functional test. So a blocking antibody will say you have autoantibodies to the folate receptor. It doesn't identify this as IgG or IgM. However, a binding antibody test that is provided now measures only IgG antibody. So by measuring only one of these two tests, you may miss the antibodies. So my recommendation is that you have them tested for both blocking as well as binding.
Okay. If the parent is CFD, so if a mother does the testing before pregnancy, obviously we've talked a lot about taking folic acid during pregnancy, but what might that indicate? I mean, I don't know that studies have been done on this yet, but what would that suggest about passing that on?
Could you repeat that question? I missed the first part of the...
Sure. This person is asking about a mother, if she tests for CFD before her pregnancy and determines...
CFD or folate receptor antibodies?
It would be the folate receptor antibodies. So say she has blocking and binding or both, and she is planning to get pregnant. Obviously, folic acid is recommended in all pregnancies. Is there anything else? I mean, is it likely to be passed on? Do we know anything about how that passes?
Okay. It's difficult to comment on this subject, especially since there are no well-designed clinical trials showing one way or the other. However, from a general perspective, if a mother is positive for the folate receptor antibodies, she should be taking relatively high doses of folic acid and not just the prenatal folic acid, just to try and overcome any effects of the antibodies, to make sure that even in the presence of the antibodies, adequate folate is going to the fetus.
I know you've talked about this quite a bit already on the hour, but I think some people joined a little bit late, so I'm just hoping we can reiterate. You talked about high-dose folinic acid, so in terms of side effects, I think what you've explained is that it's typically excreted, but can you repeat what you said about taking high-dose folinic acid in terms of risk?
So folinic acid does not pose any toxicological or metabolic risks because it's a water-soluble vitamin. It's readily excreted from the system. There is a certain amount that goes into tissues and cells. Again, it's used up quite readily. So a daily flux of folinic acid or a folate, any form of folate, is needed for our normal maintenance of different organs and the body system. The daily flux of folate into the brain seems to be also very critical for maintaining brain function, such as the production of neurotransmitters. So clearly, using the milligram doses that we have prescribing for both autism and more so now, it's being used quite a bit in depression to make sure that these people with depression get high doses of folate into the brain. And it seems to be helping. Talking to psychiatrists seems to be helping these people with depression also in terms of taking large doses of methylfolate or folinic acid.
All right.
And known side effects described so far.
Okay. I know you've talked a bit about the relationship between B vitamins and administration of folate. I've had quite a few questions. Parents are asking about synergy, different things that you would suggest would need to be taken together if anything's known from the research. Can you revisit that just a bit?
Yeah, something I would also like to revisit is the fact that not all patients respond very well to folinic acid treatment. That is because autism spectrum disorder, is basically a basket of many things happening here. Especially if there is a coexisting genetic abnormality, there is a coexisting mitochondrial abnormality. Clearly, these patients may not all respond to high-dose folinic acid. So from a treatment point of view, a physician would have to look at all of these other aspects before initiating treatment. Yeah, what was the other question?
They were just asking about B vitamins, about the connection between B vitamins and folinic acid and their use.
I mean, folinic acid is one of the B vitamins. They're all water-soluble vitamins, so taking them on a regular basis has not posed any problems. People have been taking them as a supplement for centuries, well, at least a few decades.